Hello, dear students. Ms. Khan here again. Today we'll be talking about major mood disorders. I hope this presentation today finds you in best of your moods and spirits and your health while we're talking about major mood disorders. The objectives of this presentation is to identify the symptoms of major depressive and bipolar depressive disorders. And when we talk about bipolar depressive disorder, it is also known as manic depressive disorder. Also, we will identify the role of antidepressants in management of depressive disorders, and we will also discuss some non-pharmacological interventions for the treatment. So what is depression? It is actually a mood disturbance, which is accompanied usually, there's just an overall feeling of extreme sadness all the time. The patients feel despaired. Their self-esteem is often very compromised. They lose interest in activities of daily living, relationships, just the life itself in general. And overall, they just think negative. They had the mind is just flooded by pessimistic thoughts. And this brings me to the next question. What is it to you? My hope and prayer is that to most of you this glass is half full. But believe it or not, for many, especially the patients who are going through diagnosed or undiagnosed depression, it is half empty. It is half empty. And believe me, it's not easy to look at this glass as half empty. And this feeling of despair and sadness and emptiness all the time, it's not easy. So what we can do as nurses is to know what is this disorder, what are the symptoms, and how can we help our patients. And this is what we're going to do in this presentation. So how does it manifest itself? Some of the manifestations are very prominent. Energy, there's a lack of energy, anhedonia, which is overall they just don't feel happy. Patients, there's a lack of pleasure in activities of normal living. They're overall feeling anxious all the time. They're sluggish. Many patients are just, they can't relax. It also causes change in their eating patterns. And as a consequence, it impacts their gastrointestinal system, it impacts their sleep, and it also causes some somatic symptoms. If you remember from your somatic disorders, what happens that even though there are no physiological underlying etiology, but the physical symptoms are already there because of the psychological symptoms. And also in our first week, we talked about finding the balance between the physiological wellness of our patients and the psychological well-being of our patients. So depression actually greatly negatively impacts the physiological well-being of our patients. So they would report fatigue, their gastrointestinal symptoms, sometimes often constipation, but sometimes it can be diarrhea too. Their change in bowel habits, they're not able to sleep well. There's lack of appetite. Some patients actually in depression, they tend to eat a lot because they seek comfort in food. So they end up gaining weight. There is a overall feeling of helplessness and then hopelessness. Additionally, there's a blunted effect, there's poor grooming, just taking care of themselves overall, the normal daily hygiene, they do not conduct that. There's psychomotor retardation, the physical activities is slowed down, the posture is slumped, they're restless oftentimes, they show little or no effort to interact with people, they become socially isolated, they verbalize minimal, they do not respond if they are talked to, or as less as possible. And there are certain group of people who are at higher risk than others. And you will ask me, Ms. Khan, why do I need to know that? You need to know those risk factors because these are these group of people are at higher risk, they're more susceptible to be undergoing depression. So it will help us identify just by looking at their symptoms if they are actually depressed, because many times depression may go undiagnosed. And if it doesn't get diagnosed promptly or properly, these patients often get no care or no help. So in addition to family history and the female gender, age over 65, there are some very obvious factors that can make patients susceptible to depression, which is stressful life events. If they have a presence of medical illness, of course, that poses a lot of anxiety and stress and depression and feeling of isolation and hopelessness. Postpartum period, that has been very well researched, depression, comorbid anxiety or personality disorders, or substance abuse can pose patients at risk for depression. And also, if there is a trauma that occurred early in life for patient, many times patients fail to recover from them, and the depression lasts for a long time unless some support and expert professional help is sought. So how do we help these patients? Milieu therapy, I have advocated for this therapy over and over again, which is basically providing them with safe therapeutic environment, an environment to communicate, to open up, to express their feelings, to be able to communicate, for conflict resolution. Uh, so any encounter should be an opportunity for milieu therapy to provide them support, to lead them to appropriate resources, encouraging them for communication, for self-care, just little things, taking a walk, reaching out to a friend, going for coffee, doing something they might enjoy, enjoying the sunlight, taking a bath, turning on some music. Simple things, baby steps can help them. Another component of managing depression that a lot of patients do not contemplate is use of antidepressants, because depression do has physiological component, and we will talk about antidepressants in a separate assignment. We'll talk about it in detail, but I would like to emphasize that make sure that we are educating our patients regarding antidepressants. A lot of them do start on antidepressants, but they're not compliant because they do not see the results right away, and they just discontinue medication suddenly. Let your patients know that antidepressants can take 1 to 3 weeks to even show initial effect, and it may take up to 2 months to reach maximal response. So as nurses, it is our job to educate our patients. So this is just kind of summarizing what I talked about early: developing a healthier sleeping routine, seeking therapy, setting small goals, reaching out to a friend, or learning something new, or getting creative. Tiny baby steps can go a long way when tackling depression. Now, this brings us to our other mood disorder, which is bipolar manic depressive disorder. This disorder is where patients they actually experience two end of the spectrum, and there are manic characteristics and then there are depressive characteristics. So when they are suffering from manic characteristics, they have persistent elevated mood. We call it euphoria. Sometimes they could be agitated and irritable, but they do not like getting interfered by anyone, or they do not like criticism. They just talk too much, and when they talk, there is continuous flight of ideas and they switch from one topic to another. They have this grandiose view of themselves and their abilities, and they spend their money impulsively, and many times they just give away their belongings and possessions. They're often very demanding and manipulative, and their judgment is very impaired. They would also exhibit attention-seeking behaviors. They would just dress up all flashy and wear a lot of makeup, and sometimes their behavior would be to the point of being inappropriate just for the sake of seeking attention. On the depressive side, on the other hand, they would be very isolated socially and even occupationally. They would deny they have any illness. They would not be able to sleep much. There would be poor grooming. They would not actually be able to perform daily activities of living. They would even ignore their nutrition and hydration. And there might be a component of delusions and hallucinations in depressive episodes. So this is just a picture. I found a very nice picture, and it will give you a very nice overview of manic episodes versus depressive episodes. And you can see that both of them are on the opposite end of the spectrum. So you can look at it. It will help you just remember manic versus depressive. So how do we manage these patients? These patients, they should be handled with great care. Milieu therapy is, again, um, it is effective, but many times these patients may need admission in the acute care mental health facilities. These patients can be subjected to suicidal thoughts, so they should be evaluated carefully. And when we have these patients, we need to make sure that we are minimizing the distractions because many times they're just like we mentioned that in when they are in their manic phase or depressive phase, there's hallucinations or delusion, or there are flight of ideas. The distractions should be kept to minimum. The noise, music, anything that could escalate to their behavior. But we have to do it very carefully where the patients are not feeling that they're being isolated. They should still feel supported, and the therapeutic environment and safe environment should still be provided to them. Also, patients should not be involved in the activities that require a very high level of concentration or very detailed concentration instructions. Antidepressants, again, there are a lot of antidepressants from different classes that we will talk about it in our assignment in detail. But some of them, Prozac and Trazodone and amitriptyline and Effexor, venlafaxine. So these are some of the commonly prescribed antidepressants that we have that are used. Lithium is an old antidepressant which tends to be highly addictive and it has a lot of side effects, but still it has been used and it's still being used for bipolar disorders, but we still need to be made sure that the lithium levels are monitored closely and the labs are drawn properly. Electroconvulsive therapy, I know when we say that, it tends to have a negative connotation and there's a stigma attached to it because of its use in the past. It was being used in the past on conscious patients, and seizures were introduced to those conscious patients. And a lot of patients in the past, the treatment was cruel, and patients were ending up with fractured spines. But with more sophisticated paralytic agents and anesthetics in place, electroconvulsive therapy has become very sophisticated and effective. As a matter of fact, in bipolar depression treatment, it is one of the most effective therapy. So that is another option. If all the medications and pharmaceutical therapies have not worked properly for those patients, electroconvulsive therapy is still an option. Psychotherapy is also a good therapy that we will talk about in our group presentations in details, and that is used for bipolar disorders. So let's talk about a practice question. A nurse is caring for a patient or client who has major depressive disorder. Which of the following should the nurse identify as a risk factor for depression? Patient is male, has a history of chronic bronchitis, recent deaths in patient's family, family history of depression, and personal history of panic disorder. So we talked about the risk factors. If you keep in mind, male sex is not a risk factor. Actually, it's a female sex, so we can cross that out. We talked about over and over again that physiological health and psychological health are actually They do impact each other greatly. So yes, presence of a chronic condition does impact psychological health, and patients are more susceptible to depression. So that is the right option. Recent death in the client's family, the stressful events is the right option. Family history is a right risk factor. And personal history of panic disorder, yes, another comorbidity of anxiety is also a risk factor. So let's see what's the answer. Select all that apply. The history of anxiety or personality disorder, depressive disorders are more likely to occur when client has a family history of depression. Depressive disorders are likely to occur patient is experiencing high amount of stress, and they're common for the clients who have chronic medical conditions. So I hope that this presentation helps you understand depression a little bit more. And we have to be very mindful when we are dealing with these patients, and not only patients, but people around us who are undergoing depression, because many times this disorder, or this condition, I should rather say, it stays undiagnosed. So as nurses, if it gives you at least if a little bit of knowledge, I hope that it will I would empower you to help your loved ones and families and friends to reach out and offer them help and support, to check on your loved ones and do whatever you can, and just to be there for each other. And if you are actually feeling any of these symptoms, please feel free to reach out and seek support. So if you have any questions and concerns, my dear students, please feel free to reach out, email me, and I will see you on your in your face-to-face session. Thank you. Have a good day.